Hello friends. So this is the Palmer's point here, that is 3 centimeter below the costal margin in the mid clavicular line, and here is the Mishra's point, that is over the rib. So Palmer point is the most important attractive site of the primary port position whenever you are doing Meckel's diverticulum or ventral hernia or the umbilical hernia or the epigastric hernia. And the Mishra's point is the stretched Palmer point. So once you stretch the abdominal wall caudally, then this point will become a stretched Palmer point, that is called Mishra's point. So we will put the Veress needle at this point. This is a labor number knife and we are giving one small stab wound. And after that Veress needle will be introduced and you should point the Veress needle towards the stomach, and nasogastric tube is must. So here this is the 3 click. First click due to aponeurosis of the external oblique, then aponeurosis of internal oblique, and then peritoneum. And this is irrigation. Irrigation test, fluid is going clearly, and suction test, only the bubble is coming in the suction test. And then you can do hanging drop test. So in the suction test you have seen only bubble has come. That means you are inside the abdominal cavity. And if you are in the muscle, then your suction test will not be positive, your fluid will come out. So here just we have pulled it little bit to show you that how the suction test is important and how the bubble comes. And after that you will detach the syringe and you put hanging drop test. Just you put few drop of saline and lift the abdominal wall, and this saline which is hanging will be sucked in. So suction test, irrigation test and hanging drop test all is positive. And after that we will start insufflation. So Palmer's point or Mishra point is very important point if you want to do Meckel's diverticulum. This patient is a 28-year-old man and he has already gone appendectomy 1 year ago, and after that he has again pain, and then the CT contrast has shown that there is a diverticulitis and he has the Meckel's diverticulum. So now we can see Pneumoperitoneum is going up and actual pressure is increasing. And with this camera, we are showing you the quadromanometric indicator of the insufflator. And here preset pressure is kept at 15 and slowly actual pressure is increasing. So in the Meckel's diverticulum, you should not keep the telescope in umbilicus or supraumbilical. Otherwise, your elevation angle of the telescope will become 90 degree and it will be very struggling to perform surgery. So Meckel's always should be performed with the telescope in the Palmer's point or Mishra's point, so that you can walk over to the bowel nicely and we can find out the Meckel's. Because most of the time in the ileum it is just below the umbilicus. If you will walk over to the ileum, you can find the easily the diverticulitis. So we can see homogeneous distension is going up, tympanic sound started forming all over the abdomen, and minimum amount of the gas will be 1.5 liter and maximum 6 liter will be required to achieve, and the actual pressure should reach to the preset pressure. Here this is tympanic sound. If you will palpate by your hand, then it will also called in some of the book that sound like a ripe watermelon will form once the CO2 enters into the abdominal cavity. So the flow rate here is 1 liter per minute. So introduce approximately 3.5 liter gas, approximately 4-minute time will be taken, and it is always better to have slow insufflation. So we are waiting for actual pressure to reach to the preset pressure, and now it is almost reaching the actual pressure to preset. So it's over. After that, once you stretch the Mishra's point down and create pneumoperitoneum, after once the pneumoperitoneum will properly form, after that it will remain stretched down. Don't think that in Mishra's point we go through the intercostal or we go through breaking the rib. No, it is basically a stretched palmar point, and after pneumoperitoneum it remains stretched down because of the stretched abdominal wall. And once you remove the gas after at the end of the surgery, then again it go over the rib. So this is the first optical port which we are introducing, and you should point it towards the stomach. And once the stomach is deflated, there is no chance that you can puncture the stomach. And this is the hissing sound come, and then we will take the trocar out, and after that cannula will be cleaned by a small gauze piece, and then we will introduce the telescope. So now telescope is inside, and we will do initial diagnostic, and we will check the abdominal cavity and attach the gas again and increase the flow rate to 10 liter per minute. After that second port we will put 10 centimeter lateral on the same anterior axillary line. Here we will put the second port, and this port will be here will be the your target. Suppose this is your target, then the in the snuff box there is a palmar and thumb is the second port. So this port we will use as a working port, and if the traction of the Meckel's diverticulum is required, then we can use the striker mini alligator, or we can use any other grasper to lift it. Initially it is 5 mm, but once we will put endo-GI linear stapler, then we will convert this to the 12 mm, because endo-GI linear stapler is required for the Meckel's diverticulum to cut, and the advantage is longitudinally once you will cut, gastric mucosa also will be little bit cut out. So here we can see OT light was decreased, because once laparoscopy is started you need a dark operation theater, and now our vision is on the screen, and this is the diagnostic laparoscopy which is starting. So first we should try to move the small bowel loops one by one, and we should try to find out and locate the Meckel's diverticulum. So we can see this is a small bowel, and this is a bowel grasper, that is a atraumatic grasper, which is moving the small bowel and walking over to find out that where is the Meckel's, and it is found there. Here it is. This is the Meckel's diverticulum, and it is originating from the antimesenteric border of the small intestine. We can see it has some adhesion at the tip, and those adhesions are with the mesentery. So this is the Meckel's, which is originating from the antimesenteric border of the small intestine, and this is the ileum through which it is. So you can now clearly see the loop of the ileum, and this is Meckel's diverticulum. Now we will, just to keep it lifted up and to facilitate the adhesiolisis, we will put a striker mini alligator from the umbilicus, and we will do the adhesiolisis so that we can free the entire Meckel's, so that we can fire the endo-GI linear stapler. These adhesion which you are seeing from the tip of the Meckel's is due to the previous diverticulitis, and this is a striker mini alligator which is holding the Meckel's, and with the harmonic we will do the adhesiolisis. So all these adhesions has to be separated. And we should reach up to the base. This is the base where we will fire the endo-GI linear stapler, that is blue color cartridge. So now this is the endo-GI linear stapler from Covidian, and we have introduced it with a disposable 12 mm port. It can articulate also completely 60-degree, and it can rotate also. So basically it is called roticulator because it can roticulate and articulate. After that it is holding at the base. Right now this is in the grasper mode. So we will make it sure that there should not be any stricture of the small intestine. And then you will fire the stapler, and then it is cutting it. And just in the one shot, the diverticulectomy is over. We can see some of the unused staples are dropping here. Now you will open the endo bag. Here we are using commercially available endo bag, and then drop the resected Meckels, and then we will bring it out. So thank you very much for watching this video. This was just a simple case of the Meckel's diverticulectomy with endo-GI linear stapler. Thank you very much. Have a